What an inspiring talk. I think the two of you really managed to put across every single issue in your remarks just now in such a way that's so human that all of us can certainly identify. Thank you. And I think you certainly stimulated, activated, all of us in trying to get to the same endpoint, as you said, the goal-oriented, approach. So we have a little time for some questions. He's willing to take some questions. So if there are anyone who have some comments or questions, please come up to the microphone. Please identify yourself first.
Yes, Arnold Iser, Philadelphia. Regarding the public policy regarding advanced directives, there's no public policy that works when it's usually observed in the breach. So about 20% of people have completed an advanced directive ahead of time. In about 2002, I published an article with a medical student in the American Journal of Bioethics that at the time you get your health insurance, if you're an adult with decisional capacity, you would have to complete an advanced directive at that time and then update it periodically, perhaps at 5 or 10-year intervals, so that by the time you actually, for most people actually need it, they would have experience with advanced directives.
Well, I think you're speaking to a core idea, which is that we have to make it normal to ask these questions. I think advanced directives are one way of doing that. I think one of the challenging things out of Laura Carsonson's work is that people's minds change considerably, especially as they go from not experiencing serious illness or frailty to suddenly experiencing it and then finding that their life begins to change. You can't live in your home anymore, or it's hard to keep doing certain kinds of things, and yet you also find you're really finding great satisfaction in other parts of your life. So the idea, and it's been demonstrated in places like La Crosse, Wisconsin, and other parts of the country, that where you see 80% having advanced directives. The most important part to me is that some of the most vulnerable people, the people who are in the assisted living homes and nursing homes, so the average person in assisted living is 83 years old. They have about 15 months that they're in assisted living. The most common pathway is that they then go to an emergency room visit, and there's been no discussion, no plan. That emergency room visit goes one of two ways. They die in the hospital, or they end up needing substantially more care and moving to a 24-hour nursing facility. And that comes every time as a complete surprise to people. A crisis where people are flying in from all over the country, and there's been no plan and no discussion. And you can see places around the country where that is not the norm. That the norm is that you've had these discussions as families, with caregivers, with an advanced directive and a plan for being able to have ways to honor them. So I think it's sort of the building blocks. How do you go from 20% to what we need? I would start with the most seriously ill and also those fragile groups where we know there's a pathway that has to be connected. But I think we're also seeing a flowering of willingness, even in everything from death over dinner and death cafes, a willingness to begin to articulate what these goals are and make it known.
Okay, thank you.
Good morning. Thank you very much for this time. Number one is it's an honor to be here. As a person and not as a CMS employee, I want to say thank you to all of you. As a consumer, this topic has been on my radar for almost 55 years. Okay, I'm a nurse. I started out in neurology, neurosurgery at New York Hospital, decided to try the community and became a visiting nurse and loved it and decided this is where the action is. This is where people want their health care. This is where people live. This is where people love. This is where people are. And we in the healthcare system have ignored it because we wanted to be more efficient and operational and maybe even had some bad directives that dissuaded us from really focusing on the end goal, which is what you're talking about today. And I have to say, I think partly, no offense, it's because you're culturally sensitive. I think in America we try to be...
I'm not supposed to do that.
Okay, I'll cut to the chase. I think being culturally sensitive makes us all aware of how that person wants to be. I can't say that you are me or you are me, and no offense, you're not even me. I'm only me, and if you don't ask me what I want, well, shame on you. And as a customer, I not only have big bucks to spend, but you have an obligation and a responsibility that you have been shamefully misplaced. And I, as a consumer, am angry. And I feel like Charleston Heston screaming out of the window in one of the movies, I've had enough. I've had enough of this bad care. And I applaud the IOM, and I read all of your publications, for taking the leadership and recognizing where harm existed and not being afraid or publicly intimidated or politically maneuvered, and talk the truth. And I thank you for that. And now that it's taken me way too long to get into the position of authority, because nurses don't have a lot of authority. No offense, we're the most trusted, rational professional out there, and we have no authority, no control, no money. We are slaves to the system, and I left it. Don't treat me that way. I came here to care. Don't treat me like I don't have a voice. So I went out and developed a 20-year history of international business.
What would be the question you would want to zero in on here?
Thank you. Thank you for focusing me. So during the meeting this morning with the two senators and the president, she said, I have two components, philosophical and practical, to providing health care. I would add that third dimension. She was seeking and used the word humane. Your book is totally about being human. That's my first point. My second point is that the toolkits and the clearinghouse can be filtered through national organizations and focused on tweeting, because you're right. The next generation has to be tweeted, otherwise they're not going to pay any attention. End of story. IT important. And the third, and that includes maybe the evolution of this kind of program, we have to remove the word patient from every document. We have the same kind of problem Dr. William Thomas had when he developed the Eden alternative with nurses' aides being called Shabazim. We have to create a new vocabulary. And you're right, Dr. Gawande. You mentioned it before, and I just want to thank you very much.
Thank you.
So I'm Marian Grant from the University of Maryland School of Nursing, and I heard you speak so wonderfully on this topic at the Palliative Care Assembly in Philadelphia a month ago. And I think it would be helpful for us to know a little bit more about your project on where do we go with helping people with the questions. And to this room full of very motivated people, how can we help you?
Well, thank you, and thanks for bringing up the project. So I run a laboratory called Ariadne Labs. It's the other part of my life that isn't quite as well known, but it's a laboratory where we try to develop scalable system solutions. The approach that we're testing is how can you make it so it is actually the norm in a health system, in a local health system, to deliver on these conversations at the critical moments in people's lives. So we're testing it now at the Dana-Farber Cancer Institute and the Brigham and Women's Hospital. We've been able to get 80% of the clinicians to voluntarily enroll at the Dana-Farber for the oncology patients, and we have the primary care physicians who are taking care of 60% of the patients as well. And the core question that we wanted to foster was for people who have serious illness, you wouldn't be surprised if they died in the next year, that it became normal to have these conversations. What we found is what's found nationally. Less than a third of the time are they having a conversation. It's usually in the last couple weeks of life about what people might want. And we found that by teaching a 2.5-hour clinical skills course for the clinicians, and then further that by teaching, sending materials to the patients saying that this is a conversation that your doctor is likely to have with you, and you might want to start this conversation with your own family about your condition and giving them some tools to do that. Number one, it was acceptable. Didn't have anger. People are participating in it. We're only partway through the trial, so I caution about not being quite ready to say we have results yet. What we're seeing so far in the early data is that as people follow through on all the way to the end of their care, that so far we have published this, that anxiety is significantly lower in the group who have the doctors who are trained, and we randomized half the physicians we did not train in this way, and there was a striking difference. The second part of it is that they're having the conversations about double the time more, and it's happening far earlier in the care. It's a step-by-step process. How do you make it so these conversations, which require skill, can backfire on us? We want it to be able to be something that can spread across the health system when everybody can't have a palliative care expert at their hands, at their side. And so I think it's creating these models that are fundamentally important. Try to find out if there's funding to do this kind of work. We're scrambling so that we can spread this to just 3 or 4 partners across the country when it's something that needs to be able to spread much more widely. But that research funding just isn't there for that.
Take just a couple of short questions.
Okay.
Hi,
Last two.
I'm Dr. Gowande. Thank you for your book and your voice. I'm Clarine Winsek. I'm a nurse from Virginia Commonwealth University Health System in Richmond. I am a critical care nurse and a palliative care nurse. I run a palliative care unit, and I'm representing the American Association of Critical Care Nurses here today, where I'll be the incoming president-elect. So my question for you is our paradigm in this country is ICU by default. We don't ask the question. So perhaps you've already described it with your initiative with Arion Labs. Are you seeing anybody who's doing this well in terms of asking the question when it comes to ICU care before you enter those doors?
Yeah, what the great frustration that I hear from ICU nurses and doctors, and the research has shown, is that by the time people are in the ICU, if they've not had these discussions, it's too late to be able to have a meaningful set of discussions around it. And so what we are finding is that whether it's the Respecting Choices program in Wisconsin, there's one called Vital Talk out of Duke University, that there are programs like this. They're all being created on a shoestring. And they're demonstrating real value and effort, that they mostly involve a couple key components. You identify the people who are at highest risk. You measure whether they're actually having these conversations or there's a big gap. And you have to coach the clinicians and also the people themselves and their families in going ahead and having it normal to have these conversations. And you can get to very high levels of people having that conversation and resulting in far better care.
Thank you very much.
Last question. And I'm sorry to the others.
Hi, I'm Joanne Lynn from Altarum Institute Center for Elder Care. Glad to hear your conversation and to see how well the book's been received. And obviously there's a tremendous amount of enthusiasm behind it. I'd just like to call on you to spend the last couple minutes of your time talking about the things beyond the conversation. As you know, we have a proposal to try to figure out how to take care of most of us who are going to live a long time in those assisted living facilities or the similar equivalent, or like your sister, Senator Warner's sister taking care of your mother for a decade. Most of us will have frailty, and most of us will have that long, long phase. It seems that his shift, Senator Warner's shift, to talking about care planning instead of advanced care planning is a piece of the evolution. It isn't really about CPR and ICUs. It's really about spoon feeding and keeping the body clean. The ongoing expenses of living in a disabled state are our big gamble. And it seems that the money that your dad saved needs to come back into the system somehow to expand the choices, because so many people now, right now, face choices of there being no way to get food delivered, there being no housing that's appropriate for their disability, there being no caregivers trained to deal with their issues. So the evolution into this enormous rise in the numbers of us who are all going to be old, sick, and frail together demands getting beyond the conversation, which is an important first step, of course, but into measurement systems that actually reflect what matters. We're ensconcing measurement systems that are all professional standards around 50-year-olds, not the kinds of things you're talking about. And then how to build the options so that people can live vibrantly and fully with substantial disability at 90. Otherwise, it seems that we're really facing either wiping out the economy by continuing to do the stupid things we do now, or we are facing learning to walk away from people and allowing them to die miserably because we aren't willing to provide food and housing. So, how do you see the next steps? Beyond. Let's assume we actually get people talking about it. Then what do we do?
I feel silly telling you of all people. I mean, Joanne Lynn, you should know, is one of the pioneers in this field, has been incredibly important. And the surprise question that I just told you about is part of what she invented. And the capability of understanding that, what I think your work now at Altarm Institute is allowing you to do. When we start to realize we haven't asked people what their priorities are for the end of their lives, it's really what is the priority for the life that you have in the state that you're in, and you suddenly realize it's not just asking, we haven't asked those questions at those last few weeks of life, we haven't asked those questions at any time that you start to need help along the way. And then it leads to the redesign of many of our places of elder care, trying to make the services more available in the home, but fundamentally starting with that premise, what are the most important goals for you to begin with, and how do we use our resources and our system to make them most possible? Right now, they're only used for, well, we can tackle the disease, but instead end up in this blind alley no matter what. And so what, to my surprise, 2/3 of my book ended up being about the ways in which these failures occur years before you come to the end. It's that moment when you have a parent who you have to talk to them about, you shouldn't have the car keys anymore. Or maybe it's time to, with my dad, as his arm became paralyzed 4 years before he died, that you maybe shouldn't be doing surgery anymore. And then we don't have those supports for when people have the same levels of disability, and focus those supports on not just safety and survival, but on what's needed at the end. So I'll just finish by saying I think the most important lesson on that score is we've built our systems for around what the market is asking for, and the market is not what elderly people are asking for. The market is what the children of the elderly people are asking for. And so one person who's in elder housing said to me, they are the people who make the decision and I have to sell to them. And they said, safety is what we want for those we love, but autonomy is what we want for ourselves. And we all forget that. And I think the fundamental question is, can we move even in our metrics from whether we're safe in our hospitals and nursing homes and elsewhere, to whether people know whether we're maximizing our autonomy? Do people understand our priorities, and are they helping us achieve them along the way?
Thank you. Thank you. Thank you. So we're due for a break. Dr. Gwande is here. I know I cut some of you off. You can catch him before he gets off to the airport. But I do say that there's one message I also got out of this. As I look at the audience, I think next time moving forward, we're going to engage more younger people to be part of this conversation, right? Yes, thank you. 15-minute break.